There is data that says, hey, if you have a congestive heart failure patient managed by a cardiologist, they live longer. And that's partly because we use echo to monitor it and manage it, which a lot of general practitioners can't do. And I think some of that is the commitment of the family. I think it's biased. That data is the commitment of the family tends to be higher in patients who will accept a referral.
Hello, VetFolio Voice. Welcome back. I'm so glad you're here. This episode is brought to you by Boehringer Ingelheim Animal Health and features Dr. Whit Church, who joined me to talk about mitral valve disease and its management. We got to have this conversation live on the soundstage at VMX. I always love the ability to meet with people in person, and definitely when we get to do these with all of you, so I can ask my questions and you can join in with some of your questions as well. We had some good ones at the end of this talk, so thank you to anyone who was in attendance and decided to stop by. So many of us in general practice we're balancing a lot right now. We're managing busy clinic schedules and clients with different needs, as well as cost of care considerations. So we want to make sure that when we're recommending diagnostics, we're recommending treatments, that those recommendations are targeted and that we're confident that they're going to influence our plan in some way and provide a benefit to the pet and their family. When we're talking about mitral valve disease, something that's so common, these questions come up of, when do we recommend diagnostics? When do we start treatment? And the answers, they're just not always straightforward. So Dr. Church was great in helping to break down how to think about that workup. For example, do we start talking about chest x-rays and echocardiograms as soon as we hear a murmur, or is there a little bit more nuance to it? And it turns out the answer is the universal answer to medicine, which is it depends. It depends on the client, it depends on the patient, it depends on any comorbidities and the circumstances surrounding the pet. So that made me feel a little bit better about the fact that I feel like it's not always straightforward. Turns out it's not, and Dr. Church was really helpful in navigating some of those nuances that we're up against. We also talked about different treatment options and when to consider different treatment options, when to consider referral, how to think about follow-up, and how the approach might change in predisposed breeds. For example, like a Cavalier King Charles Spaniel. Oh, absolutely love those pups. Their heart disease just kills me because they're just the most wonderful dogs. Dr. Church was a fantastic guest, very relatable, very easy to talk to, and like I said, he made me feel a lot better about my approach in these cases and being able to navigate some of the variations in every different situation. Let me go ahead and introduce him, and we'll talk mitral valve disease. Dr. Whit M. Church earned his DVM from Oregon State University in 2002. After graduation, he completed a one-year small animal rotating internship at Cornell University, and he then completed a cardiology residency at both the University of Illinois and the University of Pennsylvania. He moved from Philadelphia to Arizona and started Desert Veterinary Medical Specialists in the Phoenix Valley. He has also served as adjunct faculty at Midwestern University College of Veterinary Medicine. Dr. Church is board certified in the American College of Veterinary Internal Medicine, subspecialty of cardiology. Let's go ahead and get into our talk.
Are you passionate about animals and love helping people? In the fast-paced world of veterinary medicine, exceptional client communication is just as important as quality pet care. As a customer service representative, you're the heartbeat of the practice, the first and last person clients see. You provide comfort, support, and trust in every interaction. This course is designed just for you. It's interactive and practical, featuring real-world in-clinic video scenarios, engaging knowledge checks, and printable resources to give you the tools, confidence, and strategies to handle any challenge and elevate the client experience. Register today for the Certified Veterinary Client Service Representative course on vetfolio.com.
Thanks, everybody. Thanks, Dr. Church, for being here to talk cardiology. I feel like no matter how many conversations I have about cardiology, I always learn something new because I just never quite feel like I can really wrap my head around it. So I'm glad we're having this conversation today.
Yeah, hey, thanks for having me. I feel the same way. I just attended another cardiologist lecture and was taking pictures of the screen. And so, yeah, same.
I can't tell you how much better that makes me feel about my cardiology knowledge. Well, thinking of monitoring patients, there are certain patients that are more prone to heart disease than others that sometimes we're watching a little bit more closely. Can you talk about that a little bit? Which patients are we monitoring more closely and what are we looking for?
Yeah, I mean, the thing that's great about veterinary medicine is if you know the breed, you can already know a lot about them. I mean, it's same in human medicine. If you know what your parents died of or what your grandparents died of, it tells us more about what we're likely to die from than any other random disease. And it's the same in veterinary medicine, where, if they bring in a dog that I'd never seen the breed before, never heard of the breed, I feel a little apprehensive. I'm not sure what's going to happen and what I'm going to find. But if you bring in a Cavalier King Charles Spaniel, I'm pretty sure I know what's going to happen. And so a lot of the breeds that we're worried about for mitral valve disease is the Cavalier King Charles Spaniel. I see probably one of those a day.
Really?
I average about 5 a week. And so if we haven't seen one, on Monday, we're going to see 2 on Tuesday. But another thing is I'm in Phoenix, Arizona, and we see a lot of Chihuahuas. And when I first got there, I thought, is it just because of my proximity to, the Southwest? Why am I seeing Chihuahuas? But there was a good study out of the University of Minnesota that showed that Chihuahuas, their most common cause of death is degenerative valve disease or mitral valve disease. So other dogs on that list would be Maltese, Catons, Dachshunds. And I usually say any little white dog. Westies, for some reason, don't tend to get it much. Pugs don't really get it.
Okay.
But most small breed dogs, that's going to be their most common form of heart disease that they get. May not be their most common cause of death, but those ones I listed, we're really worried about.
Sure. I feel like toy poodles, miniature poodles are another breed I feel like I see a lot.
Poodles for sure.
And is it like the small fluffy dog, like the toy in the miniatures, or are we seeing it in standards as well?
I mean, not as much the standard. I will see it occasionally, but
Sure.
no, there's something magical about less than 30 pounds.
Yeah, when we shrink them down.
Yeah.
So if we're watching any dog, I suppose, but certainly one of these at-risk breeds, and we diagnose a heart murmur, but this is asymptomatic, it's newly diagnosed. What are your recommendations for follow-up in these patients? How soon should we see them back? And, I guess at what point do we start thinking diagnostics in these guys?
Well, some of it depends on the family.
Universal answer.
Like if the family feels very anxious, or anytime they say, these are my children, that's kind of like a clue for me. It's like, we're probably going to start diagnostics sooner, right? But in general, for like the general practitioner, I would say you probably want to listen. Once you hear a heart murmur, you're grading the murmur. So a patient who has a grade 1 or a grade 2 out of 6 left apical systolic murmur, which we would consider a mitral murmur, you probably can relax a little bit about that patient, even to the point of doing dentals and giving IV fluids. 1 or 2 out of 6 is uncommonly associated with a patient that has advanced valve disease. Okay. But then if you said, okay, now this patient has a 3, as soon as we start saying 3, that's a kind of a tweener. A 4 or 5 is much more likely to have heart enlargement and I guess more scary disease. But the patient that's a 3 is probably the toughest. And I feel for the general practitioners who have clients who want, let's say, dental work done, but they have a 3 out of 6 heart murmur. Their dog does. But they don't want to pay for an echo or a referral. So then I would say do a chest radiograph. And a chest radiograph, we have very specific criteria. Especially, I'm part of a group called the Cardiac Education Group, and we spell out for them, okay, if they have this certain size heart, using measurement schemes like the vertebral heart size and the vertebral left atrial size, with a radiograph, you can tell if they're ready for treatment, for pre-heart failure treatment, or they're still okay to just keep monitoring. And so really some imaging, once they're a 3 out of 6 and above, is important. It may only be important once a year. A lot of times I'll say, well, okay, we did x-ray you, or let's say we echoed you and we didn't find enough heart enlargement to make us concerned. And I usually say, see you in 12 months. And they may come back in that amount of time and have an auscultation. And if they don't have some major escalation in their valve disease, or their murmur, they probably haven't had a major escalation in their valve disease. It's not 100%, and sometimes they can have a 3 out of 6 murmur and their heart enlargement has progressed quite a bit, but often the murmur maintaining the same intensity is a good sign. Now, once you get to 4 out of 6, then kind of the murmur isn't that useful anymore. You know that it's loud. Going from a 4 to a 5 isn't all that common. They often will stay 4 out of 5 the rest of their life, even through congestive heart failure phase. So I would say soft heart murmur, you're probably safe. And anything 3 and above, we should do some imaging, either radiographs or an echo. Now, let's say they can't afford that. Then I would talk about doing a BMP test, like a biomarker. Usually BMP over troponin. We recommend BMP. If BMP is normal, then it's pretty good predictive value that their heart enlargement is not likely severe enough to put them at a high risk for congestive heart failure. And we probably could say, hey, well, we're going to recheck you. So that's ideally imaging. Biomarker maybe as a distant second choice.
Okay. I feel like those parameters are hugely helpful because I did take that away from another cardiology talk of someone saying in mitral valve disease, the intensity of the murmur often does correlate with the severity of the disease to a point. So, but then it begs the question of like, okay, but at what point do we start to get concerned? And so I feel like those parameters, I can take those out and just apply them and have a relatively good idea of how to approach most patients, unless of course we have the owner that says, this is my child, in which case we do all the diagnostics right away.
Yeah, then you're echoing them when it's a 1 out of 6, but usually most of the time I'm echoing 3 out of 6 and above.
Okay.
But on occasion I might do a 2 out of 6. A 1 out of 6, I'm usually rolling my eyes a little bit like, I don't know that we need to do this.
Sure.
Yeah.
Sure. What if we're doing the imaging and we're documenting progressive heart enlargement, but we have a patient who's asymptomatic? Can you talk about treatment and intervention and when we should start thinking about intervening?
Yeah. So if we do the imaging, let's say the X-ray, let's say they decided they didn't want an echo, but they okayed the X-ray. Mm-hmm. We do an X-ray, even if they just okay one lateral radiograph, a right lateral. We do a vertebral heart size. We do a vertebral left atrial size. Mm-hmm. These two measurement schemes. If the vertebral heart size is 11.5 or greater, then statistically we'd say that patient is going to qualify for stage B2 valve disease. And stage B valve disease is when they're asymptomatic, but we know they have disease. They have a murmur. Mm-hmm. Where we divide it into B1 and B2, where B1 is little to no heart enlargement and B2 is enough heart enlargement to justify treatment. And we think that they're going to progress to congestive heart failure. And because there's so many dogs that have a murmur that will never get congestive heart failure, will never need treatment. So we were trying to use imaging to distinguish those two groups. And if we get a VHS greater than or equal to 11.5, we're going to start treatment. If we do a vertebral left atrial size, the VLAS, and that is greater than 3, and really for me, more like 2.8. Some of the papers say we should wait till they're 3. Then we're going to start treatment. And the treatment is pretty much VetMedin, or currently is the only FDA-approved drug for B2. In fact, it recently received FDA approval for stage B2. It was previously approved for C. We were using it off-label for B2, and that was because of the EPIC study, which I'm one of the authors on the EPIC study, so I'm a big fan of using it in B2, and it's dramatically changed my practice. It will delay congestive heart failure dramatically. In fact, in the study, was like 360 dogs in the study. If you were on pimobendan, from the time you started the study, you went 41 months without having congestive heart failure, where if you were on placebo, it was 15 to 20 months less than that. So you went into congestive heart failure 15 to 20 months earlier.
Yeah. Well, and this is with a vertebral heart score of greater than 11.5, which is, to me, that feels like significant enlargement that I'm seeing.
It
on
can be.
X-rays.
It can be.
That's a huge difference.
It's hopefully ruling out the dogs that are not likely to develop congestive heart failure, at least not anytime soon. And there were dogs in the study that did not go into congestive heart failure. We couldn't include all of those dogs in the per protocol portion of the study because they didn't reach the primary endpoint. But of the dogs that went into congestive heart failure, that was the difference. It was 15 and a half months on average. And if you got a reduction in heart size, which was 60% of the dogs in the study, then you did even better. So it has the ability to reduce heart size. Now, if you're doing the study was really based on echo. Echo, there's different criteria. It was a left atrium aortic ratio greater than 1.6 or a left ventricular diameter index to body weight of greater than 1.7. So there's echo criteria too, but most people are interested in the radiographic criteria because they're like, well, let the cardiologist decide on the echo. I need to know what it is for the chest x-ray.
Right.
And it's safe enough that probably if you're a little bit early, it's okay. Being dramatically early in stage B1 is probably not a good idea. There is one study showing that if you give it to patients who have no heart enlargement at all, that it may damage the valve prematurely. And so that's why we're using imaging to make sure we're getting the B2. I would rather be a tiny bit early than really late in B2 because the B2 plus patients that are almost going into congestive heart failure, I don't think do as well. I think there is a window where you should definitely start it. And anytime after that, you should start it. It's kind of like, when's the best time to plant a tree? Well, 20 years ago, but now the best time would be today, right? If you want trees in your yard. And I think the same, but I think the best time is early B2.
Sure, where we're going to get that more dramatic effect that was seen with the EPIC trial. Elvie brought up that yes, a lot of times we do leave the decisions based on echo to the cardiologist, and we want to know the radiographic findings in GP. Can you talk a little bit about the differences radiographically versus echo? Are there times where, we can get a lot of information off of radiographs? Echo would be great, but we can get a lot of information off of radiographs, and other times where we really need to push for that echo if we have a client who maybe is resistant to it.
Yeah. I mean, the one spot where I think it is the most important is, let's say you take a radiograph on a patient who has a 3 out of 6 heart murmur and you do your measurement schemes. You think it looks a little bit big. You think the shape of the atrium is not right. The left atrium looks enlarged, that backpack sign on the lateral.
Right.
Or the cowboy, the splayed legs of the cowboy on the VD. Well, if you do your measurement schemes, and let's say the vertebral heart size is 11.3 and the VLAS is 2.3. You're not hitting your criteria for obvious stage B2 heart enlargement. Sometimes those patients will have echo criteria that say, yes, you should start treatment. This is B2. And so if you're getting equivocal numbers, echo can solve that because echo is just more precise. I mean, we're measuring the ventricle and the atrium down to the 10th of a millimeter. And we will talk about, the change in heart size sometimes to the 10th of a millimeter. I mean, I don't usually make too much out of that, but the reality is there's plenty of dogs who don't qualify for vetmedin or B2 heart enlargement on radiographs, but they do on echo. And so that's partly why we say echo is the best.
So in a lot of cases, especially that grade 3 out of 6 murmur above, ideally, we really want that information from the echo. But it sounds like what you're saying is, especially if we're starting to get those where they're kind of borderline and we can't quite make the call off of radiographs, then those are the cases where it's even more valuable to have that information and really know for sure what's going on with our patients.
Yeah, and let's say they don't want a referral, or let's say you live in a place where you don't have that option. Sure. I mean, I'm trying to think of some middle of nowhere towns. I don't want to mention anyone in particular, but there's some in Arizona. I mean, some people are driving 7 hours to come see me, and there's some people that just can't do that, right?
Yeah.
And so one other thing that you could do is you can do what's called VHS velocity. You can measure VHS velocity. So let's say I did the VHS and it was 10.2 when I first heard the 3 out of 6 heart murmur. And if I say, okay, 10.2, that's normal. So you should be good. Let's see you in 12 months. In 12 months, they come back and now it's 11.2. Well, it's not hitting our criteria for stage B2 purely based on the VHS number, but the velocity is not good. That's too fast of a velocity. Peter Lohr did a paper where he showed that if there's a 0.08 increase in vertebral heart size per month, that velocity, that VHS velocity suggests patient is going to develop congestive heart failure in the next 6 months. So if it looks like they had, even over a 6-month period, if you had a half of a vertebral body increase, you went from 10.2 to 10.7, we would recommend starting VetMedin. Now, that's not in the consensus statement by the ACVIM. The cardiac education group, our group of cardiologists, we would strongly recommend starting VetMedin in that patient.
Okay, that's another good parameter to keep in mind when we're hitting those limitations with diagnostics. Can we switch gears a little bit to our patients who do become clinical? And we're monitoring a patient with clinical signs, and maybe they're doing, they're managed and they're doing okay. How do we think about monitoring patients who are showing clinical signs?
So monitoring is really, I guess, diverse in what people do. When at my practice, I use ultrasound a little bit more than I use radiographs. Some people just say, hey, once they're already in congestive heart failure, they went through stage B2 with VetMedin, or we didn't catch them then, unfortunately. They went into stage C. We immediately would put them on Lasix, enalapril, VetMedin, and often spironolactone, at least, if not right away, usually within the first few months,
Okay.
6 months, let's say. And then you'd say, all right, well, what am I doing with the ultrasound, or what am I doing with x-rays? Why can't I just watch for the return of the clinical signs?
Right.
And one reason why I like to do imaging is, and especially ultrasound, number one, I charge actually less for like a brief ultrasound than I do for a chest x-ray. And that's just how my practice is. Chest x-rays, we have a fixed cost. I don't have as much control over it. So I use a lot of ultrasound. And one of the things I'm looking for is their left atrium getting bigger? Is the left ventricle getting bigger? We can estimate left atrial pressures, or we call it left heart filling pressures. I can tell you what the left atrial pressure is sometimes by the velocity of the mitral regurgitation. If that velocity starts going down, that means the left atrial pressures are rising. And when the left atrial pressures rise enough, they get pulmonary edema. So if they have rapid increase in heart size since the last recheck, then I'm likely to make a small change. I might increase their furosemide dose a little bit. If I haven't added spironolactone, I would add spironolactone. So that's one way to monitor it. If I'm a general practitioner, I think a radiograph would be another way to say, hey, well, I'm going to take an x-ray every 6 months or every 9 months or somewhere in that range. And if they have a massive increase in heart size, I'm going to increase the dose of one of those things, spironolactone, or even a little bit of Lasix, a little extra Lasix. And I think that can be very effective, maybe almost as effective as the ultrasound. And then another thing you could consider is sleeping breathing rate. If they're having any problem with sleeping breathing rate, meaning usually above 30, we're concerned. If they fall asleep, we count their breathing rate. It's usually 20 for most dogs.
Right.
And so if I go 10 above the baseline, that would be 30. And there's some pretty good studies showing that 30 is a good number. If they're above 30, we should be concerned that they're going into congestive heart failure, and we should make a change in the medication before there's an emergency visit, which are just costly and dangerous and
Stressful.
yeah.
Yeah.
I feel like our job, once we know that they have congestive heart failure, is to recheck them often enough that they don't go into the emergency room. And that's how I talk to them about it.
Right.
I'm like, I know I want to see you in 3 months. You don't want to come in 3 months, but I'm really worried about you. I made this change. I don't know if it's enough. I want to see you in 3 months to make sure that you don't end up in the emergency room.
Yeah, absolutely. And the changes that you mentioned, you talked about adding in spironolactone, adjusting Lasix, adjusting pemobendin, certainly thinking about our quadruple therapy with enalapril and everything as well. Any other medication adjustments that we should keep in mind that maybe you see patients where you're like, oh, I would have done this, but we didn't think to do it?
Yeah. Well, I think if we're talking about that quad therapy, the standard Lasix, enalapril or benazepril, vetmedin, and spironolactone in stage C, what I will often do is add something like hydrochlorothiazide.
Okay.
Hydrochlorothiazide comes as a 12.5 milligram tab, so it works pretty well in small breeds. You have to be careful. It will cause kidney failure if you give too much. And so I usually start out at once a day at like 1 mg per kg. And they just take that once a day. Sometimes I'll give it every other day, especially if they have a little bit of azotemia. I'll be more careful with it. Another option, and that can go up to as high as 2 mg per kg twice a day. So you can keep escalating that thiazide and it will work. I mean, it will almost always work. Another option is to switch from furosemide to torsemide. Torsemide is a loop diuretic like furosemide, but it's really readily absorbed. I mean, some patients don't absorb furosemide very well orally. They respond when you give them an injection, but then they don't respond to the orals. If that happens early in disease, I switch them right away to torsemide.
Okay.
But if it's like, oh no, furosemide's been working, they're clearly producing a lot of urine and it's working, but now I feel like I'm topping out on the dose a little bit, going to torsemide usually works. And so I'm usually dividing whatever the furosemide dose was by 10.
Sure.
And that's the torsemide dose. Now, if they're not doing well on the current furosemide dose, I'll divide the furosemide dose by 10 and add a little torsemide.
That makes sense.
Because I feel like I need to up the dose, and dividing it by 10 doesn't necessarily up the dose
More equivalent.
in a patient that was previously absorbing it. So we'll do that too. I mean, there's all kinds of other things you could do. You could do amlodipine. Amlodipine, we think of, oh, that's for high blood pressure. But reducing afterload, vasodilating a valve patient reduces the leak in the valve. It's like, I think of a leaky faucet. It's like if it's coming out the joint of the faucet and I have the pressure cranked way up, it's going to shoot across the room. But if I dial down the pressure, it doesn't leak as much. And you can do that to the valve. You can literally dial down the pressure by giving amlodipine. I sometimes have patients faint when I do that.
Sure.
So you have to be careful not to overdo it. I tend to give a pretty low dose, but that's something you could do even to a patient with azotemia. You can't increase the diuretic because there's the kidney values are too high. They'll stop eating if I do that. So I'll say, well, I'm going to optimize the vetmedin, maybe give it 3 times a day, add amlodipine.
That makes sense. And I think this is where cardiology, I always find it challenging because there's so much physiology that goes into it of, in this disease, we're going to reduce afterload, but in this disease, that's going to not be advantageous. That's going to be detrimental. And so when you said that, it made sense. And then I had to go back through the physiology in my head and go, okay, now I see it where we're reducing the pressure here. But that's also what makes it so interesting is that there are different areas along the way that we can tweak. But you have to kind of go back through that physiology and remember, like, where is the pressure coming from, the abnormal pressure that we're trying to resolve?
Yeah, it's fun when it works, right? It's so fun.
Exactly.
Because you're like, wow, the physiology worked. When it's not working, it's not as rewarding, but
no, it's fun.
And usually by the time they're having the azotemia, heart failure, I'm usually having a conversation with them, right? About saying, hey, we have some things we can do. They're not as effective as just upping the furosemide or switching to torsemide, but your azotemia is going to ultimately dictate how aggressive we can be with those diuretics, and try to get them to understand that, hey, we're going to try some of these other things, and usually they will work. But I kind of feel like I'm in my last 6 to 9 months of them still feeling good. And once they stop feeling, feeling well, I start to have a heart-to-heart conversation with them saying, hey, we're good at treating this disease. And usually by then we've been treating it for years. Right? If we catch them in B2, we've been treating it I usually tell people B2 on average, when you start vetmedin, 40 months, about 40 months, which is, it's over 3 years.
Yeah.
And then you're going to enter stage C. And on average, it's a little over a year in stage C, but there's lots of dogs. If we especially managed by a cardiologist, that we can get them to live 2 years after that. And sometimes they get a bonus third year. So, maybe up to 6 years. And a lot of times by then, you've educated them so much. It's still shocking. It's never fun. I hate those conversations because by then I love these people.
Absolutely.
Like they're my family clients, and that's the cool part of cardiology. Actually, valve disease is the best part of cardiology. People think it's the most boring part, but for me, it's the part where I get to know the family, and I know, they had knee replacement a year ago, and they got a new grandbaby.
Right.
Like I get to know those things, which are fun with this disease, but it does eventually end.
Right. But and like you said, at that point, a lot of times it's been managed for years, and I think those are good kind of numbers to keep in mind as far as how long to expect in each stage, depending on how they're doing, so that we can have those preparatory conversations along the way. So when we do get to that point that like you said, they're just not feeling good, we're not seeing good quality of life anymore, then it's not as much of a shock.
Yeah. And, there's some patients, when I first meet someone whose dog went into congestive heart failure, they'll say, okay, now how long do I have? And that's hard to predict, actually, because some of them, I've had them live 5 years, but a lot of it is response to therapy.
Yeah.
And so I always say response to therapy is our best prognostic indicator. If I give you, a little whiff of Lasix and an Allopril and Vetmedin, and your symptoms just resolve and you're going for 5-mile walks again. You can go to altitude, no problem. In Arizona, there's such a dramatic difference where you go to, in 3 hours, they're 6,000 feet higher, Anyway, if they have that kind of response, I'm thinking, okay, this patient is not just going to live a year.
Sure.
Like they're going to do great. I usually see them 3 months later after their first episode of congestive heart failure, do some sort of imaging. And if they get a reduction in heart size, which a lot of them do, they don't have azotemia, they're not too old. If they're 15, I'm not saying, okay, you're probably going to live 3 years.
Yeah.
I'm not giving any promises about that. In fact, I think that the older patients in B2, for instance, let's say before stage C, they do the best. Like if I give a 14-year-old, even 13-year-old Vetmedin for the first time, I'm usually saying to myself and often to them, there's a pretty good chance that if we give this treatment and you give it consistently, that you'll never have to give Lasix. Now, some of the Chihuahuas, they live to be 19 and they will need it eventually.
Right.
But if they're already in congestive heart failure and they're 13 or 14, then I worry because kidney function at that age is not great, right?
Right.
And so they often will have acute increases in BU and creatinine, and I have to lower the furosemide or start amlodipine right away. And those patients are not going to do. And that's partly what brings down the average, I think, is those old patients who go into congestive heart failure who have bad kidneys. That's going to bring down the average dramatically.
Right. In response to therapy. And then, we can end up with some really intensive management there that can be hard on the pet and hard on the family. And that's when I start to get into human animal bond and are we doing the right thing for everybody here? So even if, maybe there is a chance that they can respond, are they going to respond in a way that isn't going to have them in our office once a week and create problems for the family medicating because we're having to constantly change medications and dosages and things like that?
Yeah. And they'll get treatment fatigue. If they don't feel like their pet is not doing well, like there's just not large months of time where they're doing great.
Yeah.
They start to, get tired of that.
Right.
They start to, they get tired of stressing about their dog's health. And so I know for me, that kind of helps me also gauge how aggressive I should be. Like sometimes I can get a sense that this family is really worried about their pet. They've had 2 hospital visits in the last 3 months. I'm going to be more aggressive in that patient than a patient that has been doing great and they don't see any problem. They don't even know they can't even tell their dog's sick. I'm not going to be as aggressive for them because if it's not that broken, I don't want to mess with it.
Absolutely.
Even if they are having a slow increase in heart size, I may not mess with it. It's more of those dramatic increases, like we were talking about VHS velocity. I can see that heart enlargement velocity increase on echo as well. And if it's dramatic, I have to intervene and I'll talk to them about it. Because if you don't, they're going to end up in the emergency room. One other thing that I would say about just this, I guess, roadmap from stage B1 to stage D is, other than response to therapy, is the commitment of the family. And, if they're, a lot of times they'll praise me for helping them, saving their dog. You're like saving my dog's life. And what I usually say is, I'm just giving you advice. You're doing it.
Yeah.
And I think making them feel like they're having a big impact in their pet's life, it bonds them. And someone who loses a dog they never had to give a pill to, I just think it's unlikely that they're as bonded to that pet as the person who medicated their dog twice a day for 6 years. I mean, those people get so bonded. Even if they didn't start out bonded, they become that way. And so it's pretty cool to watch.
Yeah, absolutely. Just managing chronic diseases and the different cues that they have to learn from each other, the pet and the owner.
Yeah.
Sure. I feel like I've really kind of pushed for how do we interpret this on X-ray, and, what can we do in general practice to make these adjustments. And I appreciate all of the information because, we do run into those barriers where referral isn't an option. So I'm wondering about those cases. Where is roughly the line? I understand it could be a moving target when we should really be pushing for that referral to say this is maybe beyond what we should be handling in general practice, which again, I understand moving target for the safety of the pet and then just the best care for that pet.
Yeah. Well, there's a couple times when you could do it. One, maybe the earliest you do it is that anxious client.
Yeah.
It's only a 2 out of 6 murmur. They don't want an x-ray. They want the best possible diagnostic. Sometimes I get those. And usually I'm kind of like, I know why they sent this one. It's because of the family. It probably didn't need to have an echo, but we will do it. Right. And those clients are great clients to have because they'll do anything you tell them to do. Right. Which is so nice. Sometimes they won't stop emailing you or calling you. That's a possible time to refer. If you just have an anxious client and you can send them to the cardiologist and then they call me instead of you. Okay.
I won't argue with that one.
Another time when you might say, hey, I'm going to do a referral is if you look at the x-rays and you think this patient is a B2, but the radiographic schemes, the measurement schemes are telling you not yet. You're worried about starting vetmedin. Should I start vetmedin? Based on the radiographs, I'm not supposed to start it yet, but I feel like the shape of the left atrium suggests that it is more enlarged than the measurement schemes are telling me. I want to know for sure. Send it for an echo. The echo will rule that in or out very easily. Right. And then another time might be, let's say you did take an x-ray, your measurement schemes worked like they usually do. You started vetmedin. They're doing, they did great for a couple of years. And then the patient started to have a soft cough. If they come in and say, yeah, he has this soft cough and it's been going on for 8 months. I'm like, okay, well, has it changed a lot in the last 8 months? And if they say, no, it's about the same, like 4 months ago was the same. Yes. That's not congestive heart failure.
Okay.
Congestive heart failure comes on much more rapidly than that. Once the physiology is there for fluid or edema forming in the lung, it doesn't stop forming until you stop it, right? Until you change the physiology. And so that's something where I'd say, I'm not going to freak out that this patient is in congestive heart failure yet. We could take another x-ray, but sometimes you'll take that x-ray and the lungs don't look perfect. Mm-hmm. But if you had that history that this cough is static, I'm not actually that worried about what the lungs look like. it's probably some mild lung disease, maybe allergic bronchitis.
We see like tracheal compression from heart enlargement.
They can also have tracheal compression. I think that the bronchial compression is really, it's more like the bronchus because it's after the trachea divide. But if you get bronchial compression from left heart enlargement, it's usually a pretty mild cough. It can be very static like that. And there is often inflammation associated with that. Sometimes they actually respond to a steroid because of the inflammation. But let's say you take the x-rays. Again, there's the heart sizes there. You're not sure if it's congestive heart failure yet. The echo can tell you if the physiology is there. The echo can look at left atrial filling pressure, left atrial pressure, left heart filling pressures. We look at those things and often, sometimes they'll actually have a rise in pulmonary artery pressure. So they'll start to develop pulmonary hypertension when they go into congestive heart failure. And so that's another thing we look at on echo. And so often the echo can tell us. And even then, sometimes when we do that, we just have to trial them on furosemide. We'll give them a 2-week furosemide trial, and you could do that even before a referral. And if that was amazing, the response to therapy, maybe I don't need to refer. But the referral could happen when they enter stage C. There is data that says, hey, if you have a congestive heart failure patient managed by a cardiologist, they live longer. And that's partly because we use echo to monitor it and manage it, which a lot of general practitioners can't do. And I think some of that is the commitment of the family. I think it's biased. That data is the commitment of the family tends to be higher in patients who will accept a referral.
Sure.
Right. And so they're the ones that are like getting the renal panels and giving the pills exactly when they're supposed to and not forgetting and making sure the nutrition's right and the supplements are right. And so some of it is because the cardiologist is managing it. And I think some of that is because we tend to get the best clients.
Well,
right?
It's probably somewhere in the middle, like
Yeah.
what you're saying, that you do have these clients that are very committed, but also, like I said, using echo. As I was listening to you explain that, I was going, okay, and then if we have that information, it can probably guide our medication choices a little bit more specifically to where there's just less ambiguity there in what we're doing and how we're managing it. Maybe that's just my perception because
No.
I'm so thankful to have somebody else giving people advice on this. But it does seem like you have compliant clients and then also this very specific information to help guide how we're managing these.
Yeah. I mean, there's no question that using echo to manage congestive heart failure is valuable. I think some cardiologists would argue that they can be just as good with a radiograph and a sleeping breathing rate. And I would say it's probably pretty close. But I prefer the echo, but I also feel like a last time when you might say, hey, we're going to refer this is you've done the furosemide and allopril, vetmedin, spironolactone. You feel like you've optimized those. You feel like you're getting at the higher end of the dose of furosemide. And now you're wanting someone who does this all day, every day to take over. And that would be another instance where you'd say, okay, I'm calling Dr. Church and I'm going to send this over to him.
I can relate to that example so much as I start to get high on those doses and, struggle with it to where I'm like, yes, can I please call Dr. Church in and have him weigh in on what's going on here?
Yeah. And I'm happy to do it. Like I'll come in at any stage you want me to. Right. And my favorite is not to get a stage D patient ever. Even if I've been seeing them for 6 years, but they still can be rewarding. And it also makes the family feel like they did everything, even if they only have a few months left.
Sure.
Right.
Sure. Absolutely. I feel like if we're talking about mitral valve disease here, we have to talk about surgical repair. I'm from the University of Florida, so mitral valve repair, but there's other surgical repair options out there as well. Can you talk about those a little bit?
Yeah. So there's the edge-to-edge repair. Everyone's calling it TEER, T-E-E-R. And it's a kind of a hybrid procedure where they make an incision, an intercostal incision on the left, right near the apex of the heart. They make a cradle out of the pericardial sac and make an incision in the pericardial sac. And then similar to how we close PDAs and, do balloon valvuloplasty where we do the Seldinger technique, they do that by poking a needle through the apex of the heart, of the left ventricle, into the left ventricle. They put a wire up through the mitral valve, kind of retrograde through the mitral valve, and then take the needle out, and then over the wire, they place a catheter into the left atrium, measure pressures, do some things like that. They're guiding it with fluoroscopy and transesophageal echo, and then they insert this clamp. And what they'll do is they clamp the mitral valve in the middle, usually in the middle of the mitral valve. They select it based on the transesophageal, where they're going to clamp it. They're aiming mostly for the middle of the leaflet, or both leaflets. So connecting the anterior leaflet to the posterior leaflet, and it makes essentially a double orifice mitral valve. And it's an old surgical repair for humans, an open heart repair. And once they have it in place and they like the fact that the regurgitation is reduced enough with that one clamp, then they can unscrew the cable and the clamp stays there. And eventually it kind of heals and seals that valve together, and it can dramatically decrease the volume of regurgitation. And, it's still fairly new. And so we don't have, 10 years of data on that condition or on that treatment, but it's promising. And the cost is about $15,000. So it's not without cost and risk. There's a lot of new cardiology practices that are starting to do the procedure with kind of a learning curve. I would say this: you probably don't want to be the first case at a new practice that's doing it, because their complication rate's going to be higher. Right. Sometimes it comes loose and it's only attached to one leaflet, and many times those patients don't survive.
Okay.
And so there's some risk to it, but it's less invasive, it's less expensive. It requires a certain amount of a certain type of anatomy. If there's too much valve prolapse, it's hard to do that procedure because you can't clamp it the way you want. So they evaluate them, usually with transesophageal, and say, yes, we can do this one, or no, you have to get open heart. And at the University of Florida, or also in the UK or in Tokyo, you can get open heart. And the open heart, really, they can pretty much take on any case. They're even doing it in stage B2. And that's one other thing with the TEER, is they don't want D patients.
Sure.
They haven't had good success with D patients. They want late stage B2 or early stage C, which is always a little bit of a decision, because if you're going to go get the TEER in, let's say, B2, with medication alone, we can make you live a long time.
Right.
And so, you kind of have to go into it with the idea that, hey, I realize this is, we're kind of early. I'm going to, hopefully get the people who are most experienced doing it, who have the lowest complication rate, to give my dog the best chance. Open heart, is like $30,000. So,
or more,
or 20,000 and a trip to Tokyo.
Sure.
Yeah. It's a little cheaper in Tokyo, but you have to fly over there, right? But I mean, those guys have fantastic results. The Florida program actually utilizes a surgeon from Tokyo.
Right. So
for some reason, those Tokyo guys know how to do open heart in dogs better than anyone in the U.S.
Yeah, they've
and we need more people to be able to do it, to bring the cost down, and hopefully that's what we'll be doing eventually, or some version of TEER that is just as good as open heart.
So I'm getting the signal over here that we're getting close on time, but I want to ask you one more thing about the TEER procedure, because that one, I don't know that I would call myself familiar with either procedure, but less so with the TEER. I'm picturing, you said it creates a double orifice mitral valve. I'm picturing a lot of turbulent blood flow happening through the regurgitation that still exists. So it seems like you would still get significant left atrial enlargement, or it could break down that repair over time. Is that one of those where it's too soon to know because it's a newer procedure, or am I making that physiology up in my head?
No, I mean, by making the double orifice mitral valve, and even in open heart, you are reducing the orifice of the mitral valve when it's open, like in the normal direction. So
Okay.
you do create a little bit of mitral stenosis in both procedures,
Right.
open heart and the TEER. But in most cases, it doesn't seem to be enough to result in congestive heart failure.
Okay.
So they'll have persistent left atrial enlargement, but it will usually be a little bit reduced and the pressures will be a little bit lower. And it's like just good enough to just motor and just, go, especially in the open heart. We have a lot more, patients that have had it a long time ago.
Right.
I mean, I've had patients that had it 7 years ago. They're still alive. So,
Yeah.
are dying of something else, dying of old age. So I think it's really promising. I think if you get the right patient, TEER works very well. It's just that it's patient selection is really important. You can't just take anyone with a bad mitral valve and do TEER, where the open heart, they can.
Right. Because we're gonna.
They're repairing. They're doing annular ring, an annuloplasty. They're repairing broken chordae tendineae. I mean, they're doing what they would do in a human patient.
Right.
Short of valve replacement. It's valve repair, not valve replacement.
Sure. Yes, I misspoke there. I'm glad that you corrected that. Yes, that we're creating a repair, not quite to replacement level yet.
Not yet.
Yes.
Yeah.
I could go down this road for another hour. So I'm going to stop myself with my additional questions there and open it up to the audience. First, thank you so much for that talk. I always take away so much from these, and the parameters that you gave, I think, are hugely helpful in general practice. So thank you again for this.
Yeah, my pleasure. It was great to be with you.
Yeah, enjoyed it.
Well, I hope all of you walk away feeling better about your ability to kind of navigate these cases and all the variations that they can present. I know I definitely do. Dr. Church, thank you so much for joining me. It was such a pleasure to talk to you. Big thank you to Boehringer Ingelheim Animal Health for making this episode possible. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. For more episodes, you can click on the education tab on the VetFolio website or find us wherever you get your podcasts. Of course, I want to hear your input on this episode. I want to hear ideas for topics you'd like to hear from us in the future. So feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM or connect with me on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day. Vetmedin pimobendin chewable tablets are for use in dogs with clinical evidence of heart failure only. The most common side effects reported in field studies were poor appetite, lethargy, diarrhea, dyspnea, azotemia, weakness, and ataxia. Vetmedin should not be given in cases of hypertrophic cardiomyopathy, aortic stenosis, or any other clinical condition where an augmentation of cardiac output is inappropriate for functional or anatomical reasons. For additional information, call 888-637-4251 or see full prescribing information at docs.boehringer-ingelheim.com/pi/theras/vetmedin_pi.pdf.